Well, good morning, everybody. Thanks for coming to RRR today. Does anybody have a case or a problem or something that they want to talk about? Nobody. Well, then I came prepared for once. And why don't I go ahead and start with this patient that we had just last Tuesday, I think. And then if that sparks some interest or some conversation, or if somebody then joins and has a case, we'll go ahead and do that. We'll do that at the second part of the session here. Let me just rearrange my screen so that I could control everything. So this is an 8-year-old. I think this is a female spayed dog that presented at Davis for collection of adoptive T cells. So this dog is part of a protocol, an immunotherapy protocol for a new kind of therapy for managing cancer. She presented to her local veterinarian, I think in Washington State, for epistaxis, and you can kind of see the nasal discharge here. And then a plain radiograph or a skull radiograph at that point identified that there was a mass in the caudal nasal cavity, and then got referred to Washington State University, where more extensive evaluations were done, including a CT, which showed a large destructive nasal mass that was primarily located in the left nasal cavity. And then the oncologist there, I think, was interested in pursuing this adoptive T cell therapy for the management of these cancers. And then the place that probably the closest place that could collect these cells was Davis. So then the patient was sent to Davis. Let me just explain very briefly about this adoptive T cell therapy. So this has been developed by a company called Elias Animal Health. Usually it's I would think most oncologists now probably know about this, but and most of the work to date has been done looking at transitional cell osteosarcomas, but I think now that there's some evidence and some experience doing these cell collections for that cancer, that now people are starting to spread out and look at other kinds of cancers. What happens, particularly with the osteosarcoma, usually that's associated with a limb sparing procedure. So the leg would be amputated, and then a biopsy is taken of the tumor mass. In this case, a biopsy was taken, I'm presuming that a biopsy was taken of the nasal mass, and that's sent to Elias, and they're located in Kansas. And they make a vaccine out of that from the cells in that biopsy. And so if you're looking at an osteosarcoma, or probably any neoplasia, that the cancer cells are going to start expressing surface epitopes that are different than the normal cells. And so and they're different and unique from the normal cells. And so the vaccine then picks up, is designed to sensitize the patient to those very specific epitopes. And so once the vaccine is made, then the animal is vaccinated intradermally for about 4 vaccinal sessions over a week apart. And that vaccination strategy promotes the production of antigen-specific adoptive T cells. And so these are T cells that have been trained to just recognize the specific epitopes of the cancer cell. And then, then what we have to do, and the role of the extracorporeal program, is to collect those antigen-specific adoptive T cells. They get sent back to Elias, and they jazz them up with a bunch of cytokines, and ultimately end up making antigen-specific killer T cells that then come back to the oncologist, and those killer T cells are injected into the patient, and they go out through the dog and identify any cancer cells, and then are programmed to kill those cells. So this is a fairly new therapy for cancer. On the human side, this is one strategy that's used probably on the human side. More typically, what is used are programmed T cells. And so those are called CAR T cells, chimeric antigen responsive T cells, I think is what CAR means. And so in that case, you would just collect T cells, and then when those cells go to the lab, they transfect them with either a virus or a phage, and that's loaded with some specific genetic material that programs those T cells to recognize the cancer of interest. So that's kind of the strategy behind all of this. And now there are a lot of veterinarians around the country that have the capability of collecting these cells, and I think there's still a lot of work to verify whether this therapy is, what cancers it's going to be effective for, and its efficacy compared to traditional chemotherapy or radiation therapy. This dog did get a couple of doses of radiation for the mass. I don't know whether it was a normal dose that you would use or what, but very typically these patients then are managed without any chemotherapy. So you eliminate all of those risks. Or now maybe it's also used in conjunction with conventional therapy. For the osteosarcomas, there does appear to be a slight, I don't know if it's a slight, but there appears to be a survival benefit compared to some of the chemotherapy protocols. And in some cases, these patients have gone out for years, and there's also evidence that sometimes there might be a pulmonary metastasis that you can see gets resolved with the addition of these adoptive T cell therapies. So that's kind of the background. What I wanted to do was to take you through, and I just lost my screen here, was to take you through the extracorporeal piece that we, hang on just one second here, the extracorporeal piece that we go through to collect these cells. And leukocytophoresis or cytophoresis has to be done on a centrifugal machine. So it's a little bit different than plasma exchange, where you could do plasma exchange on either a membrane-based platform or a centrifugal platform. But these cell collections have to be done on a centrifugal platform. And it uses some of the same strategy that we use for plasma exchange, in that, as you probably know, various components of the blood can be separated with either by centrifugation or by centrifugation based on their specific gravity, where the plasma is denser than the cells. And so you can do a very hard spin and specifically and very directly separate the plasma component from the cellular component of blood. Well, it also turns out that the various cellular elements in the blood also have different specific gravities. They're more subtle, and you can see plasma up here is the lightest component of blood. And then platelets are a little bit heavier than the plasma, and the lymphocytes are a little bit heavier than platelets, and the monocytes are a little bit heavier than the lymphocytes. on and on and on until you get down to red blood cells, which are the heaviest cell in blood. In here somewhere also are stem cells. And so this is also a technique that's used to collect stem cells, hematogenously derived stem cells, primarily for, at the moment, primarily used for bone marrow transplantation in dogs and cats and dogs and people. So very differently though than for doing plasma exchange, where in plasma exchange, we spin the centrifuge very fast, use very high G forces so that we get a very discrete separation of plasma from all the other components of the blood. With cytopheresis, the centrifuge is managed a little differently, and instead of doing a hard pack, then like you would get with a crit tube, for example, the centrifuge uses much lower gravitational forces and spreads the buffy coat out over a much broader, and I'll show you an example of this in a minute, spreads the buffy coat out sufficiently that you can actually tell the machine to go in and say, I want to collect from this layer of the buffy coat, or I want to collect from this layer of the buffy coat, and you can get pretty specific at what you're collecting. On the Optia machine, and the two major machines that do this in veterinary medicine are the Optia or the Amicus machine, the Fresenius Amicus machine. They do that a little bit differently, but I'll show you what we do on the Optia. And you've probably seen pictures if you've seen any or attended any lectures on plasma exchange. You'll see that this is the connector. Here's the centrifuge sitting right in the machine, and this device right here called the connector sits in the outer rim of the centrifuge. So all the centrifugal forces are pushing in this direction from the center of the centrifuge to the outside of the centrifuge. Here's just another example. The blood comes into this long channel that goes along the outside of the centrifuge, ultimately ends up in this chamber called the connector, and this is the device that does all the magic. If you looked at a picture of the connector for plasma exchange, it might look very similar to this, but where this would all be red cells, there might be a tiny little bit of buffy coat right on the surface, just like in a crit tube, and then the reds, and most of this red stuff would be red blood cells. But in fact, all of this volume here is not red blood cells, but this is the buffy coat here, and I'll show you. I think I've got a close-up picture. Maybe it's in the next. Yeah, here it is. So here's the connector again. And we're going to be in plasma exchange. We'd collect plasma from this channel. The red blood cells that are the heaviest going to be down here at the bottom. They're going to be collected up this channel, come back to the machine, and then the cells, in this case the lymphocytes that you're going to collect, are going to come up this channel. And if we look at this same connector again, and I blew it up here. From here down to here, this is all the buffy coat, and you can see how the buffy coat has been all spread out. And it's only this tiny, tiny little layer that you see down here at the bottom that's the major red blood cell component. And you can see that little layer is going to be then pulled up by this channel, and those red blood cells are going to be returned to the patient. As will all of the rest of the buffy coat that's independent of independent of the cells that you want to collect, the cell of interest. And I'll just mention this picture right here. This is a picture. There's a camera that's focused right on this structure right here as you're starting to collect the cells. And depending on what cell layer you're collecting, if you're collecting up here at the top, you'll see those cells streaming by this tube. The camera is going to capture that, and then it displays an image on the screen which shows you that you got cells coming across. If there are no cells coming across in it, then you just got plasma. Then and if you just got platelets or some of the lighter cells, then you'll get a very light color that looks like this. And when you get a little bit deeper into the buffy coat, then the cells become, the cell collection becomes a little bit darker. And you actually judge what cell type you're collecting by the color, the density of the image that you're seeing here, and also the color of the product that's being drawn up this tube. And I'll show you that in the next couple of slides. And once this buffy coat has been created, then you tell the machine to collect from various layers. And so let's say that this is the way the buffy coat is packed. We've got plasma up here at the top. We've got platelets here right on the kind of on the surface, the lower surface of the plasma. And this is called the interface, this area here. So you're separating the plasma from the cells. And then as you get deeper and deeper into the layering here, the depth, then you collect different cell types. So these would be the lymphocytes. These would maybe these would be granulocytes, and then you get monocytes, eosinophils, and stem cells down here, and then you end up with the red cells at the very bottom. And you tell the machine to either collect high or to collect low by programming a parameter on the machine called the collection preference, which is just an arbitrary scale that tells the machine to collect from this layer, or to collect from this layer, or collect from this layer, or whatever layer. And you make that distinction based on the darkness of the product you're collecting, or the color of the product that you're collecting, as it comes up this tube out of the machine, and then you can see that. And that might be, well, here's an example of the collection preference. And so here's where, we're starting off, the machine will start off at kind of an easy collection preference to identify. Once that interface is, and if that product, the color of that product is not what you want, if it's too light, then you tell it to go a little bit deeper. So here it's starting at about 55 or 60. And then you want to collect at 50, you tell the machine collect at 50. And then ultimately it will establish an interface that allows you to collect from this region right here, which would be your lymphocytes. And you can kind of identify that by the color of the cell product that's coming up that tube. The other way that we look at this is to look, so here's the red blood cells. These are the red blood cells coming up from the bottom of the centrifuge. These are the red blood cells going back to the patient. And this is the product, the cellular product that's coming up from the centrifuge at the collection preference that you've set. And the color of this product is going to depend on how much red blood cell contamination exists in that layer of the buffy coat. And so if you have a lot of red blood cell contamination, that means you're very low in the connector. If you have very little red blood cell contamination there, then you're collecting very high at the plasma or at the platelet level. And so if you look at this color of the cells that are coming up, the cell product that's coming up, and if you want it darker, then you lower the collection preference to bring it more in line with the color of these other bars, and these bars represent a certain hematocrits that you should find in the collection preference. And then if the product is way too dark and you need a little bit lighter, then you would increase the collection preference to get the interface to localize at that location you want. So here's an example that this is the one I just showed you, and this is the collection from the patient that we just did. Most of the time I find that the lymphocytes really kind of localize at about this color. And so, and when we first started the treatment, the color of the product really was this color, even though this is from a different patient. But the lymphocytes kind of live right here at this color of product, and so that's where I wanted to collect. And we started off with this, and then we kept lowering the collection preference and lowering the collection preference until we got the color of the product that we wanted to have. So that makes sense so far. What I really wanted to do, we haven't done one of these in a while, and since I retired, there weren't too many people at the program that really knew how to do this. So they asked me if I would come in and help out, and I sort of stood in the background for a while, but I wanted to share with you some of the pitfalls we had doing this, that you gain with experience. So when you first start the collection, you hook it up just like you would a dialysis treatment, or you hook it up like you would for a plasma exchange, in that you need a double lumen catheter. Sometimes in humans, they would just do this with peripheral needles. We often don't get enough flow from peripheral. You could probably return from a peripheral needle, but you probably need at least a jugular catheter to collect the cells. And then it starts off like this, and you get a notice that saying, the machine's trying to establish an interface. And so here it's way up at this very, very high collection preference, and this is just going to be plasma. And then boy, you think, oh, good, it's going to start seeing cells, and sometimes we'd see some cells coming by. Then it dips way down here, down to the bottom, and then it comes and swings way back up here, and then it swings down again. And what's happening in this instance is the machine is trying to find the interface, and it just can't find it. And so it's searching, and to do that, it dips down. You got a real light product, and then you get a real dark product, and then you get a real light product, and then you get a real dark product. And we had established that this is kind of where we thought we wanted to collect, down and about this range. And the problem here was this interface is defined by the hematocrit of the blood coming to the machine. And so that got set wrong at the beginning when they were setting up the machine, because they took the hematocrit from the dog before it was anesthetized, and the hematocrit was 45. By the time the dog got anesthetized, and they wanted to anesthetize the dog because they thought that there was going to be some problems with breathing with all this nasal obstruction that the dog had, and so they really wanted an airway, and so they anesthetized the dog. And whenever these animals get anesthetized, as you might recognize from even doing plasma exchange, the hematocrit that they have before anesthesia and then the hematocrit that they have when they get on the table is usually significantly lower. And then when this dog got on the table for the plasma exchange, the blood pressure was a little low, and so they gave a bunch of fluids. And so this dog's hematocrit had changed from 45 down to 31. And 45 was the hematocrit that was in the machine, and the machine just couldn't figure out where the interface was at that hematocrit. And so one of the first things that you really need to do when you do these procedures is to make sure that you put in an appropriate hematocrit setting in the machine so that it knows the difference between where the plasma is and where the cells are. So when we did that, when we put that in, and here's another example where we're getting all this crazy, and what I would want, let me go back one. Look at the time here. Ordinarily, this interface is established within about 10 or 15 minutes. We're out 86 minutes. So we've spent an hour and a half fussing and fussing and fussing, trying to get the machine to establish an interface so that we could collect. And all of this time when it's doing all of this, we're just sending everything back to the patient because we don't want to put all this stuff in the bag, in the collection bag. We don't want to put all this stuff in the collection bag because it's not the product we want. So you send all of that collection back to the patient until you get an established interface. But we fussed with this for about an hour and a half before we decided to let's take another hematocrit and make sure that we're dealing in the right range. And so I would argue that an hematocrit is something you want to do right before you start the treatment. And I do this with the plasma exchange as well, although it's not as critical in the plasma exchange because the packing is so hard that it separates the plasma from the cells nicely. But you still want to have an accurate hematocrit because that establishes where in the connector the interface is going to be, whether it's going to be very high, and if it's really high, you might you might suck off some cells. And if it's really low, you probably don't care too much. But it makes a huge difference in these cell collections. And so once we put in the right hematocrit, it goes from here. And then you can see that then the machine starts to try to collect and define the interface. Ooh, I think I found it. I found it at this level. We want it at 33. And so then it steps down a little bit, gets there, and then finally it comes up and it recognizes this is where they want me to be. This is where I'm going to try to start collecting. And I forget how often these little green dots represent the density or the color, the grayscale of the collection product that's coming up the collect port. And so it finally recognizes, ooh, I'm right there. This is where they want me to be. I'm going to start collecting. At this point, we'd say, all right, go ahead and start collecting. But we wasted a lot of time, a couple of hours, trying to get this collection to stabilize. One of the other big problems that they had, this was a small dog. This was only a 20-kilo dog. They're going to send the dog home that afternoon. That later that evening, and there was so much time that had passed that they really wanted to try to collect fast, and we want to collect probably 150 mils of product, and so this is the collection rate, at this point now it's a half a mil a minute. So we got blood coming in at 23 mils a minute, and this is near the end of the treatment, and we're collecting at half a mil a minute. They had it set for a higher collection rate at 0.7 mils a minute. And what happens, particularly in a small dog or a dog where you don't have a very fast blood flow, because you have to feed these cells into the connector. If you collect too fast, you collect all the cells that are at that level, and then you exhaust all those cells, and then the machine starts collecting cells that are deeper or cells that are higher. And then when it starts doing that, it recognizes this is not what I want to collect, and then the machine will start varying again. So I came back and I said, no, let's collect at a much slower rate, because we're probably collecting all the cells that are being delivered to the connector. And in order to get more cells in the area that we want, let's increase the blood flow rate. And I think we're doing something much lower before. And the blood flow rate is determined by all of these treatments are done with regional citrate anticoagulation. And this parameter, the AC infusion rate, is a parameter that determines how much citrate is going to be delivered back to the patient. And with the cell collection, unlike a plasma exchange, with the plasma exchange, most of the citrate that you use to anticoagulate the system gets taken up in the collection bag and in the waste bag and gets thrown away. And most of the citrate that goes back to the patient is just the citrate that's in the products that they're using as a replacement product. With these cell collections, there is no waste bag, and so the citrate, there's no room for the citrate to be eliminated, and all the citrate that you use to anticoagulate the machine, it goes back to the patient. And so if you deliver that citrate too fast, the patient's going to get hypocalcemic. And so the machine's smart enough that it knows that if you want to flow this fast, this is the rate at which the citrate, and this number has units. I think it's mils of ACDA per total blood volume per hour or something like that. And if you want to go faster, then you have to accept a larger citrate return to the patient. And this now is outside the acceptable range, and it'll let you go outside the acceptable range if you need faster flow. But then you can kind of see a little yellow warning sign down here. I cut it off, but that little yellow stripe says this is not recommended infusion rate, and so if you do this, you're responsible for any consequences. And it usually means you have to give the patient more calcium on the return line. But this is the way that we were able to stabilize the interface, is slow down the collection so that you're not dissipating the cells that you're trying to collect, and increase the blood flow into the machine so that you actually deliver more cells to the level of the buffy coat that you're trying to collect. And that prevents a lot of that wandering. And this is the kind of, you'll get wandering like this, if you're starting to deplete the cells that you're actually trying to collect. What I wanted to show in this example, this is what happens every time you get an alarm, or every time the animal, if the animal moves and you get an inlet flow alarm, or if you have to, if you're going to aspirate a sample, and you disrupt this very carefully established interface, then you lose the interface, and then the machine has to come back and try to find it again. And so this, this can take 5 or 10 minutes to do this, as you can see on the thing here. So this was an inlet. I think we had a clot in the line before the citrate was delivered, and the machine got an arterial low alarm, inlet low alarm, and then you had to stop so the blood flow stopped, and when the blood flow stops, then you lose the interface, and then once you get the alarm fixed, then the machine has to find the interface again. So here it starts way up here, then it came down, and boom, and then it finally figured it out. And when all is working really, 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 really well, this is what you get. And a lot of times this is what you get throughout most of the treatment until you get alarm. The machine will fixate on the cells that you want to collect, and you'll get that collection preference, and it'll continue to deliver those kinds of cells to the product line, and you follow this and say, yeah, the color looks perfect. This is exactly where I want it to be. And here you can see the cells coming up into the collection bag. And so this is kind of ideal when you get this. This is often typically of what you get, unless that you have a very big dog, can go very fast, and the dog is very still. If you have a dog that's jumping all over the table, then you're gonna disrupt the flow in some way, and then you'll get these kind of interruptions to the nice, wonderful, peaceful, calm collection interface. This is the collection product, and actually for about a half hour we were collecting way too high, and most of this was just platelets and plasma at that point. And then finally, when we got it established, we started getting the color we wanted. This color is actually a little bit too light. The hematocrit of this is about 1.7, I think, and usually I like it to be about 2.5, or even 3. Which would be a little bit darker color than this in your final product. But this is the collection. Ordinarily, I like to collect about at least 120 mils of product, and so we actually did that. We extended the treatment. We extended the treatment out to 3.5 blood volumes of process in order to get 120 mils of product. If it was a bigger dog, I'd try to collect at least 150 mils, but usually 120 mils of product will be sufficient. And what you're looking for, you want to have about about 10 to the 9th lymphocytes in your product collection. So here's the collection from this dog. This was not a good collection, so I show you this just to point out it was okay. I mean, we went from we enriched the lymphocyte concentration from about 1,500 up to 19,000. So the yield was adequate. We had a 13 or 14% enrichment of the lymphocytes, but the purity was not so good. And by purity, we're talking about how much is this contaminated with other cells. And you can see, because there was so much collection at the very beginning that was at a very high level, that we had a lot of platelet contamination, we had a lot of neutrophil contamination, a lot of monocyte contamination. And this doesn't affect they get rid of all these cells. They do some other techniques with it to just pull out these lymphocytes. But in certain circumstances, if you're doing stem cells, you don't want all these neutrophils to be in anything that you're going to re-inject back into the patient. So this is a treatment where we got adequate yield. We'll have enough cells in there, but the purity was not as good as I would have liked. And that was because, and sometimes you just can't help it. If you got this wandering interface and you can't get it fixed, you just have to accept, well, I'm going to get some high cells and I'm going to get some low cells, and hopefully I'll collect some cells in the middle that are the cells that I want. And you just have to put up with that. There's nothing that you can do about it. This one, we could have done a little better job at the beginning. Here's an example of a little bit better collection. So this animal started off with about the same lymphocyte count. And, if you start off with a patient that only has 700 or 800 lymphocytes, then your collection is going to be tricky. Because there aren't that many cells to collect in the first place. And it's harder. If you've got a couple thousand lymphocytes, it's easier. Or if you have a great big huge dog, it's easier. Usually when we're doing osteosarcomas, these are usually 30, 40 kilo dogs. This dog was only 20 kilos. And so the collection gets to be a little bit more problematic. But here you can see we have a huge enrichment, about a 25 times enrichment. With very, very good purity, almost very few platelets, very few neutrophils, very few any other kinds of cells. And then the hematocrit on this product is 2.3. That's right where we would want it to be. And if we go back, this one was 1.7. And that's because we collected a bunch of stuff at the beginning that was didn't have a lot of red cells in it. Okay, that's all I wanted to share. Let me stop sharing now. If I can find my stop sharing. Any question about leukocytophoresis? It's fun. These are really fun treatments to do. It does take, you really have to know your machine. And the other thing, maybe a little bit different than hemodialysis, or maybe even different than plasma exchange, you really have to be very attentive to the machine. And this is not a therapy that you can set up and walk away from. You really have to pay attention to it every minute to make sure that you're collecting what you want to collect, and the interface is where it needs to be during the treatment. But they're a lot of fun to do. Then that cell product gets boxed up and sent to Kansas. And then in a few days after they enrich the cells that they want, they'll send that product back to the oncologist to deliver to the client. We have one. So I don't know that anybody's done this in cats yet. There'd be no reason you couldn't do it in cats. You'd probably have to blood prime the cats. We have done it in some small primates. We haven't, but I've been working with some people that have done it in small primates, maybe 10 or 15 kilos, 10 kilos. It's been mostly done in dogs because osteosarcomas were the targeted cancer when this was developed. And so that would be a cancer mostly of dogs, usually big dogs. So that made it easier. But I think yeah, the good thing is that, just a second, Jay. The good thing is that I think now everybody's starting to explore different cancers. Go ahead, Jay.
I was gonna say, just a shout out for the Amicus. It is a lot more straightforward on the Amicus device, and I'm assuming it's just the different modalities in terms of how the Optia makes you work for that. But I think Elias has done a good job of helping determine your white blood cell and RBC offset so that you get exactly what they're looking for in terms of the cells that they want us to collect. And I think we have some data that we haven't published yet on exactly what our yields were. On some of them, we don't always get that, but every one that we've done, they've been very happy with it, and we're able to make the product that they were hoping to make. But on the Amicus, sort of once you get it started and you have it sort of programmed for all the cycles, you don't really have to fuss with it and kind of look at offsets in between. The machine does a pretty good job. So in comparison to what you describe, I think we have a really straightforward time when we put them on the MNC collection for that, because we just kind of get them started and then sort of, keep abreast of their citrate and calcium needs. And the machine does a lot for us, which makes it easier.
Yeah, so use the term NMC. So the Optia machine does two therapies. One is called CMNC, continuous mononuclear cell collection. And then NMC, which is probably something more like what the Amicus might do, where the collection is intermittent. So it collects the cells into a reservoir, and then when that reservoir is filled up, then it pushes those cells up into the bag, which is the way the predecessor to the Optia, the Spectra machine, was designed. It was all NMC. But we've gotten used to doing the CM. Our techs wouldn't do. They'd go on strike if I told them I wanted to do MNC instead of CMNC. But they're not. I actually presented this case to present the complications. And very, very often, particularly in larger dogs, it's not as complicated as I have portrayed here. I just really wanted to highlight the problems that they had during this treatment. And I've never used the Amicus. I've seen it demoed a couple of times, but it works, as you're suggesting, Jay. It works very, very differently than the Optia, and that is the machine that Elias has really targeted for their network of providers. Thanks for those comments. Anything else? Well, we have another 20 minutes to kill. Who has a patient or something that you want to talk about? And I didn't load my other patient that I've been holding for about 6 or 8 weeks now. So long. So somebody speak up, because it's been so long since I've done that patient, I can hardly remember it anymore. How many are doing cytopheresis? Maybe raise your hand or shout out or something. So obviously the Colorado group.
We are, we did it a few years ago. And our oncology group said they didn't get, and it was with osteosarc. They said they didn't get very good results with it, but we're starting it back up in a few weeks here.
Good. And what I would say, and Erica was going to say something before I cut her off. What I would say, if you're going to set up an extracorporeal program, it ought to be as broad based as you can get. So maybe get a centrifugal machine so that you can do and you can do plasma exchange just as well on a membrane machine. But if you get a centrifugal machine as well, then you open up the door for these cellular therapies, which I think are going to become more and more prominent. If not these adoptive T cells, I think CAR T will become an issue. And there are lots of cellular therapies that are done in human patients. Probably the most common one is red blood cell exchange for sickle cell disease. We don't see that disease, but if you had a very heavily parasitized patient that has a hemolytic anemia and all the cells are infected, you might want to do a red blood cell exchange to treat the patient instead of just trying to treat the organism if it's a crisis situation, where the sickle cell patients are usually in a crisis when they present. So do as many extracorporeal modalities as you can do. That keeps the program very vital and active and often more cost effective. Erica, you were going to say something?
Yeah, I was going to say something. So we do a fair amount of cytopheresis at Penn for both Elias Animal Health and just for internal research. And two things we ran into, Larry actually talked to you about one of them. We did have a couple patients that experienced significant clotting at the lower blood flow rates. So depending on the size of the dog, we often will do a concurrent heparin CRI to try to prevent that, because at a blood flow rate of 20 mils a minute, it's not very fast. So that was one issue that we have encountered, and we had to adjust our protocols for that. And I guess the other thing I'll say is we have a relationship with the HUP, so the University of Pennsylvania apheresis unit. And because of the issues we were having, we invited them to come down. And I think it's funny how you said you can't step away from the machine. And I've definitely experienced that, like the same issues that you've had with establishing the interface, with the dog moving, and just issues with hematocrit. But when they came to visit us, literally the one thing he said to us was like, set it and forget it. He kept telling me, like, walk away, stop messing with it. So I think it is this little balance of, setting it and forgetting it, which it sounds like that's been an experience with the Amicus, but also kind of fine tuning things. Because I think in the human realm, they really are more hands off. They just don't have the personnel to really tailor each apheresis or each site apheresis collection per patient, whereas we have a little bit more ability to do that. But that's like our motto in our unit now, to me, is Erica, walk away, set it and forget it. And it's pretty good. Usually the Optia will be able to eventually find the interface if you just are patient, I'll say. So I don't know if that was some of the issues you guys had, if you were just messing around too much with the collection preference. Like, I think the machine does kind of get confused.
Yeah, I agree 100%. In fact, I've had that same comment from the technical services people when we first started. And that brings up the point that if you make any changes to anything, you need to make them very subtly. Like if you want to change the collection preference, you change it by 1 or 2 points, not 10 points or 5 points. The big problem with this one was they just had the hematocrit wacko. And you're never going to get an interface when the hematocrit that the machine has been told is very different than the real hematocrit. So you want to make sure that hematocrit is very accurate at the beginning. And then like you say, if you know that this is the level, that once you get the color of the product that you want at whatever collection preference, you just leave it and you walk away, as you're suggesting. And that works really well most of the time. The clotting issue, this dog clotted in the inlet line, and clotted in the inlet line twice. And that was another mistake they made. And we used to, and the way you establish the anticoagulation is by the blood flow to citrate flow ratio. And they had it set at 10 parts of blood to 1 part of citrate. And over the years, I found that's just not enough citrate. And so usually we should have started at a ratio of 8 or 7. Because at these low blood flow rates, as Erica suggested, you just get clotting. On plasma exchange with a tiny patient, if you got a 3 or 4, or let's say a 4 to 6 kilo patient, you're only flowing at 4 to 5 mils a minute flow, and that just is a recipe for disaster. So on plasma exchanges, when we're going that slow, most of our plasma exchanges, we also heparinize concurrently with the regional citrate, as you suggested, Erica, because most of them are IMHAs. They're all hypercoagulable, and unless you're really, really aggressive with the regional citrate, you'll get clotting. And so we very often most of the time we'll heparinize those animals as well. So I think the concurrent heparin is probably a good idea. One of the reasons not to is we were told by Elias that sometimes these cells don't like heparin, and they maybe won't be as viable with heparin as they are with citrate. I think that's one of the reasons that citrate has been more common and more popular in the human experience, because the cells just do better in citrate than they do in than they do with heparin. If you did a full heparin treatment, you could get the blood flows really fast. I mean, if you cut down the AC infusion rate, or if you use less citrate and more heparin for anticoagulation, then you could flow faster, and without worrying about hypocalcemia. So if the cells will tolerate it, that might be a better option. Is just to goose the system with a little bit more heparin so that you can get faster flows and less clotting.
When you guys are heparinizing them, are you just talking about giving IV heparin at the get-go or boluses along the way, or you actually have them on a heparin CRI in addition to the citrate that's coming through the devices?
Yeah, I usually manage them just like a dialysis patient. So we bolus them and then give them a CRI.
And that's what we do as well. I mean, I don't tend to dose as high as dialysis because we have the citrate. It's just to try to prevent that clotting right on the inlet side, like Dr. Cowgill mentioned. They don't see this in people, at least our apheresis unit. But they're doing adults, which is a different population than what we're dealing with our small patients.
They're probably flowing at 100 mils a minute.
Right.
I
Right.
mean, the biggest flow we ever get with these is maybe 35 or 40 in a huge dog. And you get a very small patient on the Optia, and then you get these really tiny blood flow rates that is just a recipe for clotting. Good comments. No, anybody else? You see a couple of microphones are off. Anybody else have any comments? Well, anyway, I would encourage you to look into that. I think there will be progressively more and more indications for cytopheresis. If not these adoptive T cells, and as Erica is suggesting that PIN, they're looking at other strategies that are probably more aligned with what are done in human patients. But in human patients now, these, in addition to cancers, and the CAR T was primarily designed to look at B-cell lymphomas. But now, I think you'll see these cells get programmed to look at epitopes for a variety of inflammatory diseases. I think they're starting to look at inflammatory bowel disease on the human side to see if you can create a cell population that would, get rid of the inflammatory cells that are creating other kinds of inflammatory profiles in patients. And so I really believe that it's going to be a therapy of the future for sure. And then if bone marrow transplantation for some of these hematologic cancers is still an option, and there are groups that believe in this, then you'll need these therapies to collect the stem cells for those patients. So a lot of opportunity for cytopheresis. And if you have a centrifugal machine, you'll use it for your plasma exchange, but then you've got the option to also do these additional therapies. And with that, if there are no other comments, we could call it a day. Jethro, you want the last word?
How can I give up that opportunity? Yeah, there I am. Yeah, no, we're actually we're just seeing our semi-chronic glomerulonephritis patients today. We're foregoing treatments, so I think she might be done with us for dialysis. But the final word overall is just wish you guys all a great weekend, and I love to hear all the collaboration and sharing of ideas. This is such a great forum. So thanks everybody for throwing stuff out there.
Thanks for the last words, Jethro. And with that, bid you all an adieu, and as he suggested, a wonderful weekend. Going to be a great weekend in California. Take care.